Good afternoon, everyone. I'm Dr Aguila, second year anesthesia assistant. And I'm here to present a case management valvular heart disease and cardiac surgery. My objectives for this afternoon is to present a case of a patient with valvular heart disease, to discuss the pathophysiology of the following valvular heart diseases: aortic regurgitation and mitral, to explain different anesthetic goals and hemodynamic needs of the valvular heart. So, um, for my case, this is a case of for a 60-year-old, 68-year-old male, a case of pathologic fracture femoral neck, right, secondary to renal osteodystrophy, status post total hip arthroplasty depth, renal osteodystrophy, and quadriceps tendon tear left. Um, and this patient is for total hip arthroplasty type. So, just a brief history. This is a self-accident case last July 25, 2004. 2 months prior to admission, patient had undergone total hip arthroplasty last July 3, 2024 under regional anesthesia undergone with no anesthetic complications. And during the interim, patient was remarkably well until 1 day prior to consult. The patient was riding in a jeep and accidentally uh, propelled his wheelchair towards someone, causing him to hit his right thigh. Patient then sought consult at um, our institution due to persistence of pain. Um, Unremarkable review of systems with the past medical history of CDL with unrecalled gear, with unrecalled medications, and seems to be non-compliant. Patient is also known to be hypertensive since 2014, prescribed with amlodipine 5 milligrams of non-compliant. The rest of the past medical history and personal and social history is unremarkable. Uh, Patient status total hip arthroplasty left in our institution undergrad with no anesthetic complications. The rest is unremarkable. Uh, the lab shows within normal limit, uh, and the chest X-ray finding only capacity symbol, so priority function, pre-carrier call. On 2D echo, um, the patient presents with 2D echo shows with ejection fraction of 56 and symptoms 66%, with the risk of concentric left ventricular hypertrophy, good conductivity, and adequate resting left ventricular systolic and diastolic functions. By atrial dilatation without visible thrombus and mitral and aortic stenosis. With mild mitral and aortic fibrillation, low probability of pulmonary hypertension. At the word, the patient presents with stable vital signs. With a 50 kilogram patient with a PFI. And for the physical examination, remarkable findings were as follows. Patient presents with heard loudness of left ICS with clavicular line with prominent thoracic kyphos. The rest is unremarkable. For my assessment, the patient is acid-free, in good airway. For my anesthetic plan is to have the following medications. Induction was unremarkable. Buprenorphine isobaric 0.5% was given and titrated the doses until the target dermatoma level was reached. Intraoperatively, there were no events or perioperative events noted. So for the salient features of my case, for the subjective findings, there's a history of CT with noted to be non-compliant with medications. And the rest of the review of systems were for my objective findings, there's a presence of crackles on pumps and murmur that left field ICS kilometer with the following echo results. So for my discussion, I will discuss about valvular heart disease, and this will mainly focus on the online case. So first, the following are the valvular heart disease case po. Highlighted or aortic regurgitation and mitral regurgitation, which is the seen problem in our patient. So alterations in loading conditions or the initial physiologic burdens imposed by valvular heart lesions, both stenotic and regurgitant. Left ventricular afterload is increasing aortic stenosis. Left ventricular preload is increasing aortic insufficiency and mitral regurgitation. And both are decreasing mitral stenosis, whereas the right ventricle faces progressively increasing left atrial and pulmonary artery pressure. Compensatory mechanism consists of chamber enlargement, myocardial hypertrophy, and variations in the vascular tone and level of sympathetic activity. These mechanisms in turn induce secondary alterations, including altered ventricular compliance, development of myocardial ischemia, cardiac arrhythmias, and progressive myocardial dysfunction. For the aortic regurgitation, this slide was discussed by Dr. Aguila at the last conference. So, brief recap na lang. The pathophysiology of aortic insufficiency in AI, blood flows laterally during diastole into the left ventricular from the aorta and leads to volume and pressure. So I will not discuss this further since this was discussed. For the management goals in patients with aortic insufficiency, management of anesthesia for non-cardiac surgery in patients with aortic regurgitation is designed to maintain forward left ventricular stroke volume, modest increase in heart rate, and modest decrease in systemic vascular resistance. And these are the reasonable hemodynamic goals during induction. Ideally, the induction drug should not decrease the heart rate or increase systemic vascular resistance. The main goal is to avoid further increase in the left ventricular wall stress, as shown in the table. The ideal heart rate is somewhat controversial. Tachycardia reduces the diastolic runoff from the aorta to the left ventricle, thereby reducing left ventricular volume and wall tension. And this increases the diastolic blood pressure and coronary perfusion region, thus offsetting any increase in the mitral valve secondary to increased heart rate. Bradycardia should be avoided as it results in ventricular distension, elevations in left atrial pressure, and pulmonary congestion. So, kung gusto nyo picture na yung slide, or since uploaded naman yung slides na sa sa Bible. So beta blockers are typically avoided in aortic insufficiency since their they reduce the heart rate and with an effect of negative inotropic effects, which may worsen aortic insufficiency. Phenylephrine must be used with caution. Ephedrine might be a better choice since ephedrine is a direct and indirect sympathomimetic amine, and as its direct effect, ephedrine activates alpha adrenergic and beta adrenergic receptor. As a direct effect, it inhibits norepinephrine reuptake and increases the release of norepinephrine from vesicles and cells. These actions combine with larger quantities of norepinephrine present in the synapse for more extended periods of time, increasing stimulation of sympathetic nervous system. Ephedrine also acts as an agonist of alpha-1, beta-1, and adrenergic receptors. The stimulation of alpha and adrenergic receptors causes the constriction of veins and rise in blood pressure. The stimulation of beta-1 adrenergic receptors increases cardiac chronotype and inotropic, and the stimulation of beta-2 adrenergic receptors causes vasodilation and bronchodilation. To increase heart rate, we may give atropine like iodine and the ratio in the table. Sorry, sorry. Yeah. Sir, so that we can, sir, in aortic insufficiency also, since there's a backflow from the ejected blood from the aorta to the ventricles. But to prevent that, sir, uh, our goal in the hemodynamic goals in aortic in patients with aortic insufficiency, uh, the heart rate must be normal or slightly increased to shorten the to shorten the period of ano, sir, of living, sir. Before there's a little phase, as systolic phase po, sir, yung contraction. To short, sir, to avoid uh, over, overfilling of the ventricles, sinashorten natin yung duration. Uh, Duration of the, shor- shorten the interval in between contractions. So, kasi how does it of the ventricular wall to avoid additional ventricular stress also. Kasi to the system circulation also. To so what so from the cardiac cycles, uh, once the during systole or ventricular contraction, blood is pumped into the aorta, the systemic circulation, and the and then the resulting in decrease in afterload pressure. Uh, yes, for the sa diastolic seizure, the purpose of our agents mentioned earlier so is to kasi sa clinical side, system system yes, mas. So, pag yung mag-diastolic uh, relaxation, sir, then uh, in closest possible in normal patients. Allowing in yes possible. What in patients with aortic insufficiency, sir, the valve remains open and and our goal is to shorten the diastolic phase. Uh, sir, nagkakaroon na ventricular overload since the blood that is supposed to be ejected to the systemic circulation backflows from the left ventricle up to the atrium. So yes, sir. Kasi idea you're just going to yes, sir. Kaya movement stay. Ngayon, pag increase. That's why you want to stage na. Kasi nga, yung gate box, 7%. Yes, sir. Yes, sir. That's why. Kasi once you know the process, okay? Okay. I don't hear the area. Now, if you know the process of then you don't do the Russian one. So I'm like, see, number one, intindihan nyo. In a way na kahit pag kasi naintindihan nyo, warrior, which is good, initiative. And so that's why I'm trying to get good process with the normal. So then for example, in aortic insufficiency, since aortic valve remains open, so when during relaxation phase or diastole phase, we need to shorten the period by increasing the heart rate to, to reach our hemodynamic ratio. Kasi in certain can you explain that? These guys, so going back to mitral regurgitation or mitral insufficiency. For the pathophysiology of mitral regurgitation, uh, this seems to be similar with aortic insufficiency. Volume overload is similar to describe with the cardinal features of aortic insufficiency and mitral regurgitation. Following a rupture of the aortic tendinae, the mitral annulus will bulge back during systole, resulting in backflow of the blood into the left atrium. The total left ventricular output consists of the forward and retrograde will be uh, decreased. So the aftermath of mitral regurgitation um, are atrial and ventricular chamber enlargement due to back and front blood flow and left ventricular wall hypertrophy to compensate for the increased wall tension from the chamber enlargement and increased blood flow. The anesthetic consideration, selection of anesthetics that promote vasodilation and tachycardia is ideal in the patients with MR, same as with patients with aortic insufficiency. However, patients with acute MR need aggressive pharmacologic management, and in the absence of acute deterioration, pharmacologic intervention is not needed usually until post-bypass. Management of anesthesia for non-cardiac surgery in patients with MR includes prevention and treatment of events that may further decrease cardiac health. And the goal is to improve forward left ventricular stroke volume and decrease the regurgitant fraction. Maintenance of a normal to slight increased heart rate is recommended. Bradycardia may result in severe left ventricular volume, and an increase in systemic vascular resistance can also cause decompensation of the left ventricle. After load reduction with a vasodilator drug such as like glucoside with or without ionization will improve left ventricular function. And in most patients, cardiac output can be maintained or with modest increase in heart rate and modest decrease in systemic vascular resistance. So going back to my case po, um, my plan my plan for my patient is to do combine epidural. The choice of anesthetic technique in this case was a challenge as it involves a rare combination of multiple valvular lesions. Neuration blockade in the form of graded epidural anesthesia that allow a gradual onset of block with avoidance of hypotension by intermittent fluid wounds and use of vasopressors. Subarachnoid block was avoided to prevent sudden hemodynamic changes. And um, some says that general anesthesia with good outcomes will have good outcomes, whereas others have reported increased pulmonary arterial pressure during laryngoscopy and tracheal intubation. Adverse effects of positive pressure ventilation and on venous return may lead to cardiac failure. Urethral anesthesia can be used, but with extreme caution in my cases. But it is otherwise to be avoided as it may lead to excessive decrease in systemic vascular resistance. And if used, our choice should be epidural anesthesia. For graded, um, graded onset of shock with less hypotension and more control of the hemodynamics. So our choice should be if you're using not contraindicated naman. So, uh, we can use either uh, neural anesthesia under epidural anesthesia first, or we can also use your general anesthesia. Um, for this case, sir, I to use nutritional anesthesia. But in other cases, should be tailored fit pa rin for the patient. Should be uh, tailored fit or appropriate for the patient. You should also consider, sir, the other lab findings po for the echo. You should grade the severity of the cardiac valvular problem. Smile. So, what that's what so for patients sir with preserved ventricular function, so so what I have mentioned, assess the seven, the valvular problem, ejection fraction. We should take that into consideration. Um, for this case, sir, I opted to use uh, sir, in ano sir, with preserved ventricular function, sir, and ano po, on review of systems, based from my history and physical examination, the patient's presence with um, heart failure symptoms, sir, I might uh, obtuse ano po, sir, pinura the anesthesia. Sir. Uh, for patients with ano, sir, preserved ano sir, with good ejection fractions also. You get the ejection fraction. For considering the mm, mm, yung afternoon to after induction. So, when adequate you know, and patients will be there. So, yes, boss. So you're right. Mm, yes, boss. Yes, boss. Oh, stop. So, yes, boss. So in patients presenting with cardiac, my GA is a better choice. Yes, po. Yes, po, sir. So you can titrate your medications. Yes, po, sir. Sir, pwede ka po. Um, sure, so, in our monitoring, blood pressure, heart rate, and brain. To the echo wise, check lang. Yes, ma'am. For our upper induction of anesthesia can be achieved with general anesthesia with the IV induction drugs. Dosing should be adjusted to prevent an increase in systemic vascular resistance or decrease in heart rate because both of these hemodynamic changes reduce cardiac output. Selection of muscle relaxants should follow the same principles. So, for example, Pantorone produces a modest increase in heart rate that can contribute to maintenance of forward left ventricular stroke. Volatile anesthetics can be administered to attenuate the undesirable increase in systemic blood pressure and systemic vascular resistance that can accompany surgical stimulation. The increase in heart rate and decrease in systemic vascular resistance, plus the minimal negative inotropic effects associated with our agents, such as isoflurane, desflurane, sevoflurane, make them all acceptable choices for the maintenance of anesthesia. Increases, we can also use ketamine also. Um, because it's has an effect on the heart rate. Still remember there's a certain make sure that you you can also really done. So just like in IRT solutions, I skip this later. Depending on the patient's vital signs, modern drug therapy for valvular heart disease may include beta blockers, calcium channel blockers, and digitalis for heart rate control, ACE and ARBs, and vasodilators to control and afternoon. And um, sir, since it can um, gratify, it can also bradycardia. Tapos ephedrine is a better choice sir, since it has effect on alpha 1 and beta receptors. So, parang yun yung sa yung main actions rin sa phenanyl alpha 1 receptor. It acts on the causing uh, effect on blood pressure that's heart rate compared with effect shocks on the alpha beta receptors, which affects the heart rate and blood pressure. So, better choice. Yes, parang the muscles ay proven from toxic effects. So, for this one, you're doing so for certain cardiac conditions such as aortic and mitral stenosis, it requires a slow heart rate to prolong the duration of diastole and improve left ventricular lead and coronary flow. But in case mentioned po, orbital valvular lesions such as aortic and mitral regurgitation, it requires after load reduction and somewhat faster heart rate to shorten the time for regurgitation. So ETL fibrillation requires a controlled ventricular response so that the activation of the sympathetic nervous system as during tracheal intubation or in response to surgical stimulation does not result in sufficient time for them to significantly decrease diastolic feeding. Diastolic feeding time ends. So, pag stenosis, mas gusto natin, sir, increase yung uh, increase yung heart rate to prolong the duration of diastole, resulting to improvement of left ventricular feeding. In regurgitation naman, the other hand, we want increased heart rate po, as mentioned earlier, shorten the time for uh, regurgitation. Ionic particles. So, this ends my report. Thank you. Sir, yung ito sir kasi yung sa case na na-encounter. Thank you.
Good day, doctors. I am Joseph Arnold Ablao, second year anesthesia resident, and I'm about to report about heart failure. For my objectives, to understand heart failure and its pathophysiology, to evaluate its presentation, diagnosis, and management, and to analyze the anesthetic considerations and anesthetic management of patients with heart failure. Heart failure is the inability of the heart to supply adequate blood flow and therefore oxygen delivery to the peripheral tissues and organs. Underperfusion of organs leads to reduced exercise capacity, fatigue, and shortness of breath. It can also lead to organ dysfunction, such as renal failure in some patients. Systolic heart failure occurs when the heart is unable to pump a sufficient amount of blood to meet the body's metabolic requirements. Clinical manifestations usually reflect the effects of the low cardiac output on tissues, such as fatigue, oxygen depth, acidosis, and the damming up of blood behind the failing ventricle, either systemic or pulmonary venous congestion or both. Cardiac output is reduced in most forms of heart failure. Inadequate oxygen delivery to the tissues is reflected. The left ventricle is most commonly involved, often with secondary involvement of the right ventricle. Diastolic dysfunction can also cause symptoms of heart failure as a result of atrial hypertension. Here are the common causes. The risk factors of heart failure include hypertension, obesity, prediabetes or diabetes, and ASCVD. The non-ischemic causes include chemotherapy, cardiotoxic medications, rheumatologic or autoimmune, endocrine or metabolic, familiar, inherited, or genetic heart disease, heart rhythm related, and substance abuse, as well as stress. For the pathophysiology, ischemic heart disease and hypertension are the two most important causes of heart failure. Other common causes include diabetes, valvular heart diseases, especially aortic stenosis and mitral regurgitation, and other cardiomyopathies. Infective and nutritional causes are still common in developing world. Advanced age and male gender are also risk factors. The mechanisms underlying ventricular dysfunction are death or dysfunction of cardiac myocytes and long-standing pressure or volume overload. Um, as myocardial contractility decreases, the stroke volume drops and the end diastolic volume and pressure increase. This, according to Frank Sterling law, will result in myocardial contractility and thus cardiac output. If sustained in the long term, this volume increases, which leads to what is termed cardiac remodeling. This involves myocardial hypertrophy, chamber enlargement, and an increase in ventricular wall stress, and increases oxygen demand. An increase in ventricular stiffness also occurs due to increased collagen deposition in the heart, which impairs feeling and exacerbates the situation. Heart failure may be diagnosed based on clinical presentation at home. Common signs and symptoms include fatigue, tachypnea, dyspnea, stress, or exertion, uh, paroxysmal nocturnal dyspnea, orthopnea, jugular vein distension, peripheral edema, evidence reduced tissue perfusion. Uh, for the presentation and diagnosis, a meticulous physician will strongly speculate congestive heart failure simply based on the patient's clinical findings. However, final diagnosis can be established with the aid of some notable diagnostic modalities, which includes the following. On most occasions, suggesting a chest X-ray usually settles the diagnosis with the help of the following diagnostic findings, such as signs of pulmonary edema, increased cardiac size, blood levels of BNP or brain natriuretic peptide can become significantly elevated in chronic heart failure. This test is also being extensively used in securing a defined diagnosis of heart failure. Um, Heart failure diagnosis confirmed. It may be determined the cause and be classified according to the ejection fraction law. Ejection fraction is a measurement expressed as a percentage of how much blood the left ventricle pumps out with each contraction. An ejection fraction of 60% means that 60% of the total amount of blood in the left ventricle is pushed out with each heartbeat. A normal heart's ejection fraction is between 55 and 70. Here's the difference between preserved ejection fraction and this ejection fraction. Our preserved ejection fraction is also referred to as diastolic heart failure. The heart muscle contracts normally, but the ventricles do not relax as they should during ventricular filling. While the reduced ejection fraction is also referred to as systolic heart failure, the heart muscle does not contract effectively, and therefore less oxygen-rich blood is pumped out to the body. The American Heart Association made stages of heart failure. There are four stages of heart failure. For stage A, at risk for heart failure, patients at risk for heart failure but without current or previous symptoms or signs of heart failure and without structural or functional heart disease or abnormal biomarkers. Patients with hypertension, CVT, diabetes, obesity, exposure to cardiotoxic agents, genetic variant for cardiomyopathy or family history of cardiomyopathy. While in stage B, pre-heart failure, patients without concurrent or previous symptoms or signs of heart failure but evidence of one of the following structural heart disease, increased filling pressures at risk or risk factors and increased natriuretic peptide levels or cardiac troponin in the absence of competing diagnosis. For our stage C, which is symptomatic heart failure, uh, the patients are already have current or previous symptoms or signs of heart failure. Um, For stage D, advanced heart failure, these are patients with marked heart failure symptoms that interfere with daily life and with recurrent hospitalizations despite attempts to optimize. On the other hand, the New York Heart Association has the classification of heart failure. The class 1 has no limitation of physical activity. Ordinary physical activity does not cause symptoms. Class 2 has a slight limitation of physical activity. Comfortable at rest. Ordinary physical activity causes symptoms. For the class 3, there is marked limitation of physical activity. Comfortable at rest, but less than ordinary activity causes symptoms. And for class 4, there is severe limitation in discomfort with any physical activity. Symptoms are present even at rest. The American Heart Association guidelines for long-term management of heart failure in adults. The vicious cycle of neurohumoral of RAA system activation, then decreasing cardiac output and cardiac remodeling is the target for the long-term treatment of heart failure. The only cure for early heart failure remains definite treatment of the cause or heart transplantation if the disease has progressed. Medical management is directed at decreasing symptoms and preventing disease progression. In the event of elective surgery, patients diagnosed with congestive heart disease pose a major anesthetic risk. Therefore, it is customary to screen all the patients who are due for an elective surgical procedure for any clinical signs of heart failure. If any sign of heart disease is evident on chest X-ray, such as patient relation, should be cautiously assessed for any major cardiovascular complications in the perioperative period, or in worst case, the surgery can be aborted. For the anesthetic agents, the most ideal candidate must be selected for anesthesia induction and maintenance. As the inhalation agents are known to alter cardiac contractility, IV drugs may be preferred. These include IV propofol and etomidate. Opioid analgesics such as remifentanil can also be useful. Overdosing on any agent should be best avoided. For the perioperative monitoring of the heart, direct arterial catheterization may be carried out for monitoring blood pressure. In addition, transesophageal echocardiography can also be a reliable tool for the evaluation of cardiac physiology in the perioperative period. Optimization of the heart contractility. Heart rate should be continually monitored, and if necessary, stimulating agents such as dopamine or dobutamine can be administered to boost the cardiac output. For the post-op evaluation, a meticulous post-op cardiac care will help a patient undergo speedy recovery from the stress of surgery. Congestive heart failure can lead to a significantly higher mortality rate during a surgical intervention. So, the cardiac performance of such patients must be optimized prior to operative intervention. Treatment of heart failure requires a substantial modification of an individual's dietary uptake as well as physical activity. In addition, a number of contributing risk factors have to be controlled optimally. For example, a good control over diabetes and hypertension, and pharmacological intervention consists of the following: angiotensin converting enzyme inhibitors, they reduce the after loop, while the diuretic drugs, they reduce the preloop, and beta blockers, they reduce the cardiac contractility. The anesthetic management of patients with heart failure depends on the degree of heart failure, the cause and nature of cardiomyopathy, and the surgical procedure. For stage A and B heart failure patients, it centers on avoiding drug interactions with their long-term therapy and maintenance of the benefits of such therapy throughout the perioperative period. Drugs that worsen heart failure should be avoided if possible, and close attention should be paid to fluid balance, analgesia, and maintenance of normothermia and sinus rhythm, and optimal treatment of any comorbid conditions. Doctors usually recommend that people with heart failure avoid calcium channel blockers other than the vasoactive types, and NSAIDs such as ibuprofen and most drugs for preventing heart arrhythmias. Patients with stage C and D heart failure, they present with significant challenges in the perioperative fluid and medical management. In addition to the challenge of anesthesia, there's little evidence that any one anesthetic technique is superior uh, to another in this group. Stable anesthesia with as little myocardial depression or change in afterload as possible is a reasonable goal for patients with heart failure. Traditionally, cardiovascular stable agents such as etomidate and benzodiazepines have been advocated both for induction and maintenance. There is little evidence for this, and the use of most IV induction drugs and volatile agents have been described. The majority of patients with disabling heart failure or stage D or symptomatic stage C are dependent on their preload to maintain their ventricular filling. Many patients with heart failure also rely on increased sympathetic tone to maintain tissue perfusion and cardiac output. Induction, emergence, and fluid shifts during perioperative period may cause the pre or afterload to move outside the narrow range in which the patient functions. Though there is no strong evidence published in that invasive arterial and central venous monitoring improves outcome, information from this monitor may help the anesthesiologist to anticipate or limit these changes. Regional techniques are an alternative to general anesthesia for certain procedures. They avoid hemodynamic instability. The same patholysis associated with neuraxial blockade may cause severe hypotension, especially if these inhibitors or ARBs have been continued preoperatively. However, moderate reduction in afterload may increase cardiac output without increasing its oxygen demand. The superior analgesia associated with well-functioning regional techniques may also limit hypertensive spells, tachycardia, and cardiac ischemia post-op. Um, Peripheral nerve blocks techniques have similar advantages and disadvantages. Though despite these considerations, there is no strong evidence that either regional or GA leads to improved survival after surgery in patients with heart failure. For the preoperative management, the usual pre-op, we obtain the history and perform a physical examination. We should investigate patients with heart failure for these laboratories, hemoglobin hematocrit, renal liver function, ECG, chest X-ray, and arterial blood gas. For the perioperative management, uh, the goal is to preserve myocardial contractility and administer adequate analgesia to minimize catecholamine release. Um, Monitoring tools such as pulse ox ECG, blood pressure, the standard monitors. This will help us check for the patient. In the induction, we pre-oxygenate with 100% oxygen. Use etomidate as a quick onset sedation agent. Uh, Combined with propofol with a vasopressor to avoid hypotension. Rapid sequence induction, so it depends on the surgery that is needed. Be aware that laryngoscopy before achieving a deep level of anesthesia may worsen pulmonary hypertension, and administer benzodiazepines or opioids during induction to decrease the sympathetic response. For the ventilation, we maintain anesthesia with volatile inhaled anesthetics. Use long protective ventilation, avoid one lung ventilation, and increase the fraction of inspired oxygen rather than pit to improve oxygenation. Here are my reference.